Thank you, Dr. Colby, and thank you, Professor Papana, and the organizers of HIV-NAT for inviting me here. What's very interesting is that it was in Bangkok almost 2 decades ago that I was in a meeting with Yup Lung starting to talk about the use of antiretrovirals for primary prevention. And as you heard from Andrew Grulich, David Cooper certainly was a leader in thinking about this issue as well. So in the United States, the US CDC estimates that there are about 1.1 million people who would benefit from PrEP based on surveillance studies. Individuals who benefit from PrEP in the US are disproportionately men who have sex with men and transgender women in particular, and people of color, particularly African Americans. Scale-up has increased a great deal over the past few years. The WHO estimates there's something close to 350,000 people who have initiated PrEP across the world. More than 200,000 of those individuals are in the United States. But the United States does not have one healthcare system. It has more than 50 healthcare systems. So these are data from PrEPview, which is a feature, a geospatial mapping feature developed by Patrick Sullivan and his colleagues at Emory University. And what you can see in the top map is the prevalence of PrEP users per 100,000 population. And we have red states and blue states and great disparities. So you can see the very dark green is the increased uptake of PrEP on the West Coast, several states in the Northeast, including my own in Massachusetts, Florida, and there are a couple green states in the South. So you say, well, that's not so bad. At least where the epidemic is happening, there's increased PrEP. But another way that they portrayed the data in the lower map is the PrEP-to-need ratio, which is the rate of new HIV infections and the number of new PrEP uptake. And there you can see that the South is really problematic. The largest number of new HIV infections are in the South. This has to do a lot with what's called assortative mixing, that people tend to have sex with people within their own race and ethnic group, particularly in the United States. It has to do with poverty. It has to do with underdeveloped healthcare systems. Many of these states have not approved the health insurance reforms that were begun under the previous administration. So you really have a perfect storm where you have some places where PrEP is increasing a great deal, and we're starting to see population level impact. And you have other places in the United States which really need to do a lot of work to catch up. And using the AIDSview data, the same group divided the U.S. into quintiles in terms of the rate of PrEP uptake, and you can see that the quintile where the PrEP uptake was the highest, there's actually a substantial decrease in HIV diagnoses between 2012 and 2016, whereas in the two lower quintiles, there's actually been an increase in the rate of new HIV infection. Now, as Andrew mentioned before, we can't attribute all of this to PrEP because these states, we call them blue states, so in my own state, the rate of HIV treatment uptake is quite high. Virologic status knowledge is high, viral suppression is higher than the average in the US. So it's a combination of both treatment as prevention as well as PrEP. Certainly our rates of STIs tell us that it's not because behavior change is greater in these blue states compared to the red states, but certainly PrEP plus treatment as prevention is showing a population level impact in the United States. Now, I work in a health center in Boston, Massachusetts that has specialization in sexual and gender minority health. We provide primary care for about 35,000 people overall. About half of those individuals are sexual and gender minority individuals, about 2,500 people living with HIV, a large number of HIV uninfected men who have sex with men and transgender women. And what we were able to do, and we presented these data at the recent prevention conference in Madrid, HIV R4P, was we compared all individuals who had at least 2 HIV tests between 2012 and 2017, because we run the biggest HIV testing and counseling program in the state. So we looked at people who were tested more than once during that period of time, and then we looked at whether they had initiated PrEP during that period of time. We were one of the original sites for the CDC PrEP safety study, and then one of the 2 US sites for IPREX. So PrEP has been very much in the DNA of the health center since 2011, and that's when clinicians started prescribing PrEP with increased uptake over the past few years. There have been now more than 4,000 PrEP starts at our clinic, and we looked at the group of people who had been tested at least twice for HIV, which was 16,128 individuals. About 25% of them had initiated PrEP. And then we looked at which individuals became newly HIV infected, where we had a documented seroconversion during that period of time. We found that the vast majority of those seroconversions were people not on PrEP, but there were 17 on people who were prescribed PrEP. Now, 12 of those individuals were people who had been prescribed PrEP but stopped it. They thought they weren't risky anymore. They had problems with adherence. They did not have an active PrEP prescription. If you look at the 5 people who did have an active PrEP prescription, the majority of individuals were either clearly non-adherent to the medication, they were taking it intermittently. That was a couple individuals. There were also a couple individuals who were in the process of HIV seroconversion. We might have had one true PrEP failure out of this group of individuals of more than 4,000 people starting PrEP, and that was questionable. The patient said to the provider that he had been adherent, but there was erratic pattern of medical refills. There's also substantial STIs, so whether it was increased biological susceptibility or whether the FDIs were a marker of increased risk at a period where there was not adherence. The clinician didn't save any blood spots during the period of time between the last negative test and the first positive test. But one potential PrEP failure. If we still use a very stringent definition of a PrEP failure, somebody who has a current PrEP prescription, whether they were taking PrEP or not, the incidence was down to 0.13% compared to people who never started PrEP who were tested more than once at the center, which was 1.43%. So certainly this suggests population level impact. But 2 other snapshots that I do think are relevant for the rollout of PrEP in the US and globally. We tracked our STI rates, bacterial STI rates, over a decade of time. And what we found was, before PrEP was available, people were either HIV infected or HIV uninfected among the male patients, the majority of whom were MSM. So you can see that there was a substantial number of STIs back in 2005 that were among HIV uninfected individuals. The red is the incursion of PrEP, which started in 2011. By 2015, a substantial number of people on PrEP were developing bacterial STIs, and you can see in the lavender line the absolute rate of STIs was going up substantially. But I would also point your attention to the fact that there were still a substantial number of HIV uninfected individuals not on PrEP who had developed a bacterial STI, and one might argue that those are individuals who should be on PrEP. So we spent a lot of time obsessing about PrEP increasing risk, and in point of fact, the risk was already increasing. Line was going up before PrEP was there. A lot of the people developing STIs are also living with HIV, so they're not candidates for PrEP. So we have to say PrEP is part of a mix in a new equation, and we'll talk more tomorrow about STIs, but certainly we don't want to be demonizing PrEP, but we really want to be using it so we can prevent new HIV infections. The other concept about PrEP, which my colleague Julia Marcus analyzed, is the idea of PrEP as a gateway to health. We think of hormonal contraception as a way in which many young women may start accessing primary care and other health problems may be uncovered. And we wondered whether PrEP might be for men who have sex with men, might be a gateway to health. So at community health centers in the United States, there are a lot of stipulations on what people services they should be receiving, such as they should be getting flu vaccinations, they should be questioned about tobacco, screened for depression. And we found that people on PrEP were more likely to have all these things done than people not on PrEP in the clinic when you controlled for all the other socio-demographic factors. So the argument might be you come in for PrEP, you get other health care needs addressed at the same time. The hemoglobin A1C or glucose testing is a little tricky in the U.S. context because we send chem panels, and the creatinine monitoring also included glucose. So we saw people were more likely to have glucose testing, but they weren't necessarily more likely to have hemoglobin A1C. So it's not that every primary care issue gets addressed by PrEP, but there is a suggestion, and it may be good to talk to policy people, that PrEP brings healthy people in and may address other healthcare needs as well. In this short space of time, it's very hard to summarize where the field is going, but just a few postcards from the edge. The U.S. healthcare system really needs additional supports to really optimize PrEP rollout. So there are a number of different experiments going on, research studies and demonstration projects. So we have something called ADAP, AIDS Drug Assistance Program, which is through the Ryan Wright Act in the U.S., which helps subsidize the cost of treatment because of people being uninsured or underinsured. So several states are now supporting PrEP-DAP, a drug assistance program that either pays for the drugs themselves, which, as you heard, are extremely expensive in the U.S., or pays for some of the laboratory monitoring and clinical visits, which can also be expensive. Another concept is called academic detailing. We find that generalists, who would be logically the people who might be providing PrEP to many citizens, are very averse to talking about sex and thinking about PrEP. Detailing is when you have pharmaceutical companies that used to go and buy lunches for people and give talks about their new drug. So the city of New York and now several other jurisdictions are training public health people to go into busy clinics and do academic detailing about PrEP. I have a colleague, Douglas Krakauer, who's looking at electronic health records and seeing whether there can be cues if somebody gets screened for an STI, if somebody comes in for post-exposure prophylaxis. Can they get an electronic message? Can that provider be reminded, this is a person you might want to talk to about PrEP? We also are trying to think about cheaper ways to make PrEP available. So Rupa Patel in St. Louis is looking at training pharmacists to be major PrEP providers. There's also this concept of PrEP navigators that we're working on, which is training peers to help people navigate to services to make sure that they get all the services they need to stay on PrEP. There's also work going on looking at home testing. The medication is quite safe and well tolerated, so why do people have to come in and see a physician every 3 months? So we actually have a project with Aaron Siegler where people are getting home kits where they can do STI testing, do a finger prick to check a tenofovir level, and get feedback online from their providers. So these are for people who are stable on PrEP to simplify PrEP. I also show you a picture of an app that we're developing. There are a bunch of apps being developed in the Adolescent Trials Network to help support PrEP for young MSM. And then globally, this whole idea of increasing access, and you'll hear about that next from Anton Pozniak. So I just want to thank several of my colleagues who contributed to some of the ideas and turn the podium over to Anton. Thank you.